Hi, everyone. My name is Dr. Haider Najjar. I'm a fertility specialist at Melbourne IVF. I'm sorry about the delay in connecting. We had some technical issues. Um, Today, we're going to do a question answer session regarding endometriosis and fibroids and the impact of those conditions on fertility. So I've got a brief presentation. Hopefully we won't bore you with it, just a small number of slides. Prior to that, I just want to introduce myself again. I'm a fertility specialist in Melbourne IVF. I teach fertility surgery to doctors in training at Monash Health. I'm an obstetrician gynecologist. So the main area of my interest and expertise in medicine is fertility and its surgery and management. And I also deliver babies as well. I do obstetrics. So as I said, I teach at Monash University, Monash Medical Center, and I work in Melbourne IVF. So I'll start with the brief presentation. I'll share with you the PowerPoint presentation. So firstly, we talk about endometriosis, and basically it's a very, very common condition where the lining of the uterus, the endometrium, grows outside the uterus, as you see in those arrows, these dark patches near the uterus and the bladder. This is a laparoscopy view, and you can see this area there, the elevated, swollen, and blisters, and the new blood vessels arising around that area. That's all typical of endometriosis. This is what we see when we do a laparoscopy. So it's very difficult to determine how common endometriosis is, but we find it in 15% of patients who have no symptoms and having a laparoscopy for other reasons like sterilization, for example. 40% of patients we do keyhole laparoscopy to check for infertility when they have no symptoms, no pain. 4 out of 10 would have endometriosis. As for those who have pain with periods or pain with sexual intercourse, when we do laparoscopy to check for endometriosis, 9 out of 10 would have endometriosis. So it's quite common. It's more common in women who have yearly, when they start the menstrual cycles early in life, women who delay their fertility later, which is very common these days, women who have heavy periods, that's the sign also of endometriosis. And what I find really staggering until today, and with the awareness of endometriosis, it takes around 8 years on average from the time that the patient starts complaining about symptoms to the time actually we reach a diagnosis, 8 long years. So I can't overemphasize the importance of actually raising the alarm if you have symptoms of endometriosis. What are the symptoms of endometriosis? A lot of patients who we see for fertility purposes have no symptoms of endometriosis, but just difficulty falling pregnant. Usually the pain is cyclical, so it's around the time of the period. It's pain with the periods, backache, deep pain with sexual intercourse, and generalized pelvic discomfort and heaviness. Sometimes women can have urinary symptoms, some urgency with the urine, but there's no correlation between the extent of the disease and the severity of the symptoms. Sometimes you see women who have quite severe disease but have minimal symptoms, and others who can have one little spot of endometriosis and will have very, very severe pain. The most common site for endometriosis, the ovaries, pelvic side wall, the pouch of Douglas, which is the deep pelvis, the bladder, and it's a common association of a condition called adenomyosis. It's when the lining of the uterus or the endometrium grows within the wall of the uterus, which is quite a tricky condition to treat. It can also grow around the bowels. Distinct area from the pelvis, like the diaphragm, the liver, the lungs, the brain, are very rare areas, but we can actually see endometriosis. There's some pictures where you can see this grape-like structure, lesions on the ovaries. The white areas you see are the ovaries, and you can see the endometriosis growing on them. This image shows you severe endometriosis, where the bowels, the ovaries, and the uterus, and the fallopian tubes are all matted together in one piece. This is quite a severe form. So that's for endometriosis. I'm sorry to rush through this quickly because I want to allow time for questions. You can see this is a picture of uterus that is affected by multiple fibroids. Fibroids are the most common benign, usually benign tumor that affects women in their fertile, gynecological tumor that affects women during their fertile life. And you can see those round lesions growing over the surface of the uterus. These are the fibroids, and this is the image we see by ultrasound. So what are the different types of fibroids? Subserosal, which when more than 50% of the fibroids growing outside the uterus, and this is the type of the subserosal fibroid, and this is another type. So they are the least, they have the least effect on fertility. Intramural, this type, which is the fibroids is totally within the wall of the uterus, and submucous fibroids, which is these two types here, when the majority of the fibroid are within the cavity of the uterus, and these are the type of fibroids that is associated with infertility. How can fibroids cause problems? Again, like endometriosis, a lot of women have fibroids and they don't have any symptoms, and we don't actually deal with or treat asymptomatic fibroids that cause problems. But big fibroids, it's understandable, they can cause pressure, they can put pressure on the bowels or the bladder, they can cause heavy periods, especially when they are close to the cavity of the uterus, like the ones I showed you earlier, and they can also lead to infertility, difficulty falling pregnant, and sometimes miscarriages. The risk of cancer and fibroids, which is a common question, is less than 1%, way under 1%. The younger you are, the less the risk of cancer and fibroid will be. Older women have higher risk, of course, of cancer and fibroids. Fibroids during pregnancy, the majority of them also don't cause problems, but sometimes they can undergo certain complications, and they can cause pain and sometimes even early birth or miscarriages as well. How do we deal with fibroids? There are lots and lots of different ways we deal with them. One of them is to do nothing for women who don't have any problems with them, just have fibroids. We remove them surgically, operation called myomectomy, which I do by keyhole surgery. And if they are only within the cavity of the uterus, these submucous fibroids that are related to fertility, usually we can use them, we can remove them by minimally invasive approach with the hysteroscope, which is without a cut. That's done like a curette procedure. We use a special camera and a special device to remove the fibroid, and this is a same day procedure, no significant recovery. Large fibroids, there are other ways of dealing with them. Sometimes we block the blood supply, the embolization of the artery, and that makes the fibroid shrink. And there's medical treatment as well, but usually medical treatment interferes with fertility, and we can use certain medications to shrink them. And there's other methods, for example, MRI guided ultrasound energy that also makes the fibroid shrink in size. So this is a diagram to show you the different fibroids and the different ways we can deal with them. So sorry I rushed through this one. Now we can go through the questions. I'm just going to look at the other screen. Sorry to go through them. Okay, so the first one we have. We get that through Instagram. Are IVF babies more likely to have autism than naturally conceived baby? Thank you for this question. It's a very, very common question. We get asked this on a daily basis, and we didn't know the answer to this Well, firstly, autism is a very complex condition, and we haven't yet unraveled all the secrets with it. But in general, all medical conditions, there is a huge research, major international study that compared IVF conceived baby to natural conceived baby, and they found no difference in the medical conditions and the diseases that people get between the two groups. What they found was very interesting, that IVF conceived baby had more visits to the hospital than the naturally conceived babies, without having more medical problems. And the reason for that, they thought maybe that when people have difficulty conceiving and they conceive with IVF, they probably a little bit more anxious, and they may have a lower threshold to go to the hospital. As far as autism concerned, there is no evidence whatsoever to suggest that babies conceived by IVF have higher risk of autism or any other condition. I hope this answers the question. The other question is another excellent question. Can acupuncture prior and post embryo transfer increase your chances of pregnancy? And again, this question has also been answered by scientific evidence, and the answer is yes. So we actually recommend acupuncture. I have personal experience with acupuncture, and it was fantastic, for musculoskeletal issues that I have from playing tennis and golf. And I found it very, very, very useful. But as far as embryo transfer concerned, in particular, yes is the answer. The next question is IVF after having 2 ectopic pregnancies and 2 miscarriages, as too afraid to try naturally after loss. Very, very interesting question. So IVF is a great solution for many, many fertility problems that we have or we deal with. Ectopic pregnancies occur when the pregnancy implants outside the cavity of the uterus, in the fallopian tubes, or on the ovaries, or in the junction between the tube and the body of the uterus. And I don't believe IVF improves the chances of achieving a not ectopic pregnancy. So I don't know if that is the answer. But if you had multiple ectopic pregnancies, the issue with that, you would have had some surgery on the fallopian tubes, and that may make conceiving naturally difficult. Or the other way to look at it also, the reason one has more than one ectopic pregnancy is there could possibly be an issue with the movement of the fallopian tube that helps transferring the embryo from the fertilization area near the ovary to the womb. And in those cases, IVF may make sense. With 2 miscarriages as well, it also depends. The majority of miscarriages occur because because the embryo itself is probably abnormal, rather than there is an issue with the womb itself. So there is a solution with IVF, especially with genetic testing of the embryos or chromosomal testing, for recurrent miscarriages as well. So I guess we can look at these 2 complex conditions in many different ways, but without knowing precisely the full history, the age, other medical issues, it is very difficult to give you a clear answer on this. A full knowledge of the situation is necessary here, but I fully understand the anxiety and the stress after 2 ectopic pregnancies and 2 miscarriages. There may be a role for IVF, and your specialist studying your full condition will be in the best position to answer these questions. I hope this is sufficient to address your question there. The next one, is it common for endometriosis to come back after it's been surgically removed? How common would that be, and how can doctors diagnose that it's come back? Okay, so endometriosis naturally comes back. This is the natural history of the condition. And as long as there is ovulation and there is menstrual cycles, the endometriosis usually reproduces, which is the lining of the uterus regrowing, and the condition will recur. The way to stop it recurring is, if you're pregnant, the pregnancy and the breastfeeding durations, that would put a hold on endometriosis. And a lot of patients after pregnancy and breastfeeding may not suffer a lot of symptoms. So full cure may not be achieved, but they would have a long period of relief from the condition. So that's the one or two things that one should think of immediately. Otherwise, if you don't treat it and you're not falling pregnant, then it will come back. It will come back at different rates. Endometriosis is never the same in two different patients that we see. It has different levels of aggression, so to speak, the different species of the condition, if you wish. So sometimes patients have recurrence of symptoms within 6 to 12 months of removing the disease. And sometimes that's without treatment. And sometimes we do surgery and patients don't have treatment and they don't have any recurrence for years later. So it is very difficult to determine how long after dealing with the condition surgically it would recur. But generally it will recur. It's a matter of how long. How can we determine this? It's usually by the recurrence of his symptoms. Usually the symptoms that triggered the intervention or the surgery, and the symptoms would bring you back, basically. Ultrasound can help in revealing moderate to severe endometriosis. If endometriosis causes cysts, then we can see those by ultrasound. And if endometriosis is moderate to severe, it can affect the genital organs, the fertility organs, the ovaries and the uterus, the way they appear on the ultrasound. They have limited mobility, limited movement because of the adhesions, and we can tell that by ultrasound. But the only way you can tell for sure is doing a laparoscopy, which is the keyhole camera to have a look and see. We don't obviously do this lightly unless the symptoms are really severe. Doing a second operation would have to be really based on significant symptoms, because every time you have surgery, it's a risk of complications and to your health. So we have to be very careful when we make those decisions. I hope this answered your question there. Do you suggest endometrial scratching? That's the next question. Excellent questions, guys, by the way. Amazing. Really, really fantastic, relevant, spot on questions. I love them. Do you suggest endometrial scratching for IVF? We used to think it's a good thing to do. And until probably 2 years ago, 18 months to 2 years ago, approximately, a big research showed no major benefit from it. So I myself used to perform it for my patients a lot, and the current evidence suggests no major benefit. So unless there is an indication for it, if we suspect that the lining of the uterus is not normal, or if you're bleeding abnormally, then that would make a good case. But just do it to improve the chances of IVF success is no more supported by evidence. How do I know if I have, next question, sorry. How do I know if I have endometriosis and what causes it? Also, what do I need to do to get rid of it? Amazing question. And I think some of the slides that I showed would answer some of these questions. How do you know if you have endometriosis? A lot of patients don't have symptoms. And if you don't have symptoms, you don't have fertility issues, it's fine. You don't have to know if you have mild endometriosis that hasn't affected your health or your fertility. Okay? We don't have to go and dig deep and find it. But usually what brings you to us is you either have pain, abnormal bleeding, all these symptoms that I listed earlier, or have difficulty conceiving. So if you have one of these issues, then we will look for it. We'll find it, we'll deal with it. What do I do? What do I need to do to get rid of it? And again, getting rid of it, it's the way we look at it, it's not so much the endometriosis that we worry about, it's you as a patient that we need to help. So we don't get too hung up on the endometriosis. We deal with your symptoms. If you have a lot of pain, sometimes surgery is warranted, medications can deal with endometriosis, or dealing with the fertility issue. Okay, obviously medications, any medications that we use for endometriosis, apart from pain medications, would interfere with the ability to conceive. So dealing with the endometriosis for fertility patients, usually, not always, usually would require surgery, or that's especially if they have symptoms. If they don't have symptoms and they have severe endometriosis, then surgery is an option, or assisted reproductive technologies, for example, IVF, can be an option. So just to recap on this is really, really important. It's not the endometriosis that we treat. We treat you. We treat the symptoms, pain, bleeding, or fertility. So I hope this is sufficient to answer your questions. Next question, does endometriosis affect egg quality? If it does, what can women do to improve egg quality? Guys, those questions are amazing. Very, very, very good question. Endometriosis, especially in moderate to severe levels, can affect your fertility by different ways. One of them is the egg, quantity and quality, which we will get back to, but it can affect the anatomy, the fallopian tubes, the cavity of the uterus, the area around the uterus. If it's heavily affected by endometriosis, the inflammation around it may interfere with the implantation of the embryo. May that have been conceived naturally or by IVF. So endometriosis can interfere with fertility. As far as the egg's concerned, yes, especially when endometriosis affects the ovaries, which is the most common site of endometriosis, and especially if it causes endometriomas, or we call them chocolate cysts, where these are cysts of endometriosis inside the ovaries. So these are severe forms of endometriosis, and their presence will eventually lead to consuming more eggs than your average, and even the surgery itself can also interfere with that. So dealing with this has to be very wise and sensible and based on experience and assessment of the whole condition and why are we dealing with it and what objective are we, looking at here. So endometriosis can affect the quantity or the number of eggs and the egg reserve. And there's a blood test called AMH that can assess the egg reserve. This is a very complex topic, and I'd love, if we had more time, I can tell you more about it. One quick thing is with endometriosis, we found after surgery, when we remove those big cysts, especially we do them for patients who have symptoms and have a lot of pain, and the egg reserve level AMH drops. But then when we do the test 6 to 12 months later, the blood test shows that the egg reserve goes up again. So we think it could be an immediate reaction that the body sort of stabilizes after. As I said, it's very complex, and I don't want to bore you with too many details. But yes, there is a direct impact. In a lot of patients that we look after who have endometriosis, they don't have that severe form. So the majority have mild form of endometriosis, and especially if it doesn't affect the ovaries, then the egg quality and quantity should not be severely or at all affected by the condition. And the second part of the question is, what can women do to improve egg quality? Unfortunately, the science and evidence showed there is not much we can do to improve the quality. The egg quality is a DNA, if you wish, determined thing. It is the only impact on the quality is age. Okay, the younger you are, the better the quality of the eggs is. As women get older, the quality of the eggs deteriorate, and the same applies to men. As men get older, the quality of the sperms deteriorate. So, if there's one message I want to leave you with tonight, would be: do not delay starting your family or finishing your family. Okay, it's very, very important to recognize the impact of age. The impact of age is much bigger and worse than the impact of endometriosis. And again, you can't reverse the clock. You can't do very much. Of course, there are basic things that we all know: quality of life, lifestyle, so weight, smoking, excessive drinking, recreational drugs. All of these things will make things worse. So all you can do is lead a healthy lifestyle, and that will protect your eggs and keep them at the best quality they can be. Next question. In terms of endometriosis, except from laparoscopy, what would be the most reliable way to monitor? What sorts of scans, investigations are the most reliable? So laparoscopy is the gold standard. It's the only way we can actually see 100% what's going on. But the other ways is, we don't do a laparoscopy on every patient that has endometriosis, only when it's deemed necessary for significant symptoms that we can't control medically and or fertility. Other patients who have an operation or we decide against surgery, we can monitor by monitoring the symptoms. We perform clinical examinations in the office with ultrasound. I perform my own ultrasounds myself, so I can actually see that live, and I can show it to my patients immediately on the screen, anything we see. Okay, so that allows me to have a much better view and control of what is happening if I perform the scan myself. Okay, and it will allow me to involve my patients immediately, instantaneously, and to help understanding. There's another level of ultrasound done by specialist gynecologists who have specific training in endometriosis scanning. There's a handful of them in Melbourne, and they are excellent people and they do amazing job. So they can give us an insight to specifically bowel involvement, and in severe cases, they can give us a lot of information that will help us in determining the need for surgery or not, and how we manage the disease going forward. So really clinical, which is symptoms, examination. Examination is a very valuable tool, and ultrasound examination. In some cases, especially with adenomyosis, when the endometriosis grows within the wall of the uterus, there are that we use MRI as well, or magnetic resonance imaging, and that can also give us an insight to that. CT scans aren't very helpful with endometriosis, but that's really what we have to mostly to work with. I think we've gone over time, but I'm loving answering those questions. So we'll answer a couple more. There's a lot of info regarding certain supplements online. Would you recommend any specific vitamins, dietary requirements? Very good question. So vitamins, dietary requirements, there's a lot of research that is happening in our institutions and all over the world that we are involved with as well, to look at causes and associations of endometriosis. And there's a lot of genetic DNA research and link with endometriosis, and we're making really good grounds, in advancing our knowledge in it. There are some indications of certain diets, but it's not so much the diet, it's actually the association of endometriosis with other conditions, like maybe irritable bowel syndrome, that makes certain diets, help. But in general, there's really no particular diet or vitamins or a dietary recommendation that I have myself. There are fantastic dietitians that the majority of endometriosis doctors like myself, we have a multidisciplinary team of dietitians, pelvic pain physiotherapist, pain specialist. The surgery and the fertility treatment that we do is just only one part of the big multidisciplinary team. So the majority of dedicated endometriosis doctors would be part of a big team, and I can refer you on to our fantastic dietitian that we work with, and I'm sure they can help, and I'm sure other specialists who do similar care would be able to help you as well. This question from, okay. Any evidence that endometriosis affects embryo implantation? We're getting really technical, guys, here. It's fantastic. I love this. So if you ask this question in our endometriosis international society meetings, that I have the privilege in presenting in many of them. Now I'm thinking of the traveling and presenting and all of that part that we in Victoria we can't do, unfortunately. So it's a very, very difficult question to answer and very controversial. There are a lot of contradicting evidence about which one you deal with, or which one would you do? Would you remove the endometriosis, or would you do IVF? And if you do IVF with endometriosis there, does it affect the chances of success? And every specialist have certain views on this. Unfortunately, it's not black and white. In my experience and the evidence I I genuinely believe endometriosis, especially in moderate to severe disease, can impact negatively on the implantation of embryos. The uterus is an organ in the pelvis, and if there is endometriosis around it, there's a whole inflammatory process and production of cytokines and all sorts of other biochemical products that the body produces to defend itself from certain conditions, including endometriosis. And these biochemical products can impact negatively on on implantation of the embryos. Okay, and I believe in moderate to severe disease. In mild disease, the evidence is also clear that a small percentage of patients may benefit, and it wouldn't affect significantly the success rate of IVF. But in severe disease, I'm in favor of dealing with the endometriosis because it may cost us some really good embryos not working because of it. Okay, maybe we'll answer this question because we went way over time, and I feel bad because we started a bit late. Please get in contact with us via. Okay, that's no evidence outcome. So just find this question. How effective is an IUI after having endometriosis? So IUI, for those who don't know, IUI refers to intrauterine insemination. Okay, we do IUI or recommend IUI if the anatomy is normal and after we establish that the fallopian tubes are patent, they open, they're not blocked, so they will allow the sperms to travel to the eggs, to fertilize the eggs, and the embryo to travel back inside the womb. So IUI requires normal anatomy. And if in cases where we remove endometriosis and the fallopian tubes and the rest of the anatomy is normal, then IUI will have a decent chance in achieving a pregnancy. It will be the same chance that IUI has in a normal anatomy if you do it soon after you remove the disease. And IUI in general, of course, it depends on the age of the female, but IUI in general, we say around 1 in 5 attempts work. So 20% on average is the chances of success of IVF. And if you do it soon after you remove the endometriosis, not long, if you do it long later, then you will allow the endometriosis more time to regrow. Then you're on the back foot again. If you do it soon, then I believe it will have that same chance of success, the good chance, which is around 20% or 1 in 5. For those who want to be in touch with us in Melbourne IVF, talk to a specialist, make an appointment. Do not hesitate to call our number. It's 1800 1800 111 483. So the number again, 1800 111 483. Or you can always visit the website that you can see there on the face book. How often, the next question, should we see a specialist like yourself to monitor endometriosis? It really depends on why you're seeing the specialist, okay? It depends on the severity of the condition. It depends on the severity of the symptoms. And I said to you, there is a whole multidisciplinary team that we work with. So, for example, my patients who I see, if they're not in a fertility mode or mood, and we perform surgery for endometriosis, and they get good relief from it, they usually go on the pill or Mirena or something. and we see them in 6 months, and if all good, see them 12 months later, and then yearly or every 2 years based on the, and of course, if they have symptoms, if there is an issue with fertility, then that needs to be attended to immediately. But if you don't have symptoms, I think 6 months, and then 12 months, and then 1 to 2 yearly after that. That's what I do with my patients. There is no hard, fast, rule for that. Are there any particular procedures or treatment to help with implantation for women with endometriosis? With dealing with the endometriosis is the way to deal with it. The implantation itself, the embryo transfer procedure, as far as IVF concerned, is the same. We do this the same way, whether you have endometriosis or not. But there are no specific procedures for implantations of the embryo. There are a lot of things that people out there, and some specialists even, promote that are not based on any evidence. We in Melbourne IVF pride ourselves by following scientific evidence. These measures that people recommend have to stand the test of science before we tell you that, okay, this will work. Okay, so there are a lot of things out there that people promote, injecting things into the uterus, doing washouts, all sorts of things that are not based on science, that we don't recommend. But every condition, every patient is different, and it's best to discuss your specific situation with your doctor. But in general, to improve the chances of implantation, if you're having implantation issues and you have endometriosis or fibroids, then they need to be removed to allow a better chance. You got to change the environment. If the environment hasn't been successful in allowing an implantation, then it makes perfect sense to normalize it, okay, to allow it to take. Are there any particular procedures or treatment to help with, we've done that. A few other questions, but I think it's just getting late for all of you guys, and I think my kids there also. So I just wanted to thank you for being amazing audience. Lovely, lovely, lovely questions. We're here and happy to help, myself and the whole team of Melbourne IVF medical staff and the nursing staff, and again, a huge team there to support you. At Melbourne IVF, we have doctors that have lots of different expertise. It's a huge spectrum. So some of us have certain expertise in male fertility, and they perform male surgery and manage them. And others like me specialize in fertility and obstetrics and delivering babies, but I specialize mostly in keyhole surgery and fertility surgery, and endometriosis and fibroids are the common conditions that we deal with. But as I said, if you check the bio of each specialist, you will have everything there. So we would love to help. If you have any question, any concern, do not hesitate to reach out. Thank you very much again. It's been delightful to be involved with this. All the best.